everyone to this Nitte Anaesthesia education series, a program intended to enrich our residents and faculty in different topics of anesthesiology in a systematic manner. This is the 8th month we are with you, and I thank you, all of you, for your wonderful support and involvement. Our Dr. Sumalata R. Shetty, the organizing secretary, has taken wonderful, painful steps to ensure that this has continued for the 8th month successfully, and we are going to continue this with all your support. This month we are going to discuss on valvular heart disease. We have Dr. Muralidhar Kanchi, one of the best persons who can discuss this subject. We have Dr. Rajesh Mane and Dr. Rashmi to deliberate a case, and Dr. Manjula is joining us with the equipment of the month. I welcome all our faculty, our resource persons, our residents, Dr. Srinivas and Dr. Shabanti, who are going to discuss the case, and also all the participants. Welcome you all. And now I hand over mic to Dr. Varun for welcoming and introducing the resource persons. Thank you. Over to Dr. Varun.
Thank you, sir. Good afternoon, one and all. I, Dr. Varun Bhaskar, from the Department of Anesthesiology and Critical Care, KSECDE Medical Academy, consider it is my pleasure to welcome today's eminent speakers, senior faculty, postgraduates, and guests to our department's 8th Nitte Anaesthesia Education Series. Our first speaker for the day is Dr. Muralidhar Kanchi. He is a senior consultant and professor of anesthesia at Narayana Institute of Cardiac Science, Bengaluru. He is a fellow in cardiothoracic anesthesia from Glenfield General Hospital, UK. And he will be conducting today's masterclass on pathophysiology of valvular heart disease relevant to anesthesia. I welcome you, sir. The second topic for the day is which will be LM family, which will be presented by Dr. Manjula, Professor of Anesthesia, St. John's Medical College, Bengaluru. She has her fellowships in regional anesthesia and pain management and in advanced airway management by IDA. And she is the IDA Bengaluru City Branch Secretary. I welcome you, madam.
Thank you, sir.
Case discussion will be on mitral stenosis patients coming for incidental surgery, which will be moderated by Dr. Rajesh Mane, Professor and Head of the Department of Anesthesiology, Jawaharlal Nehru Medical College, Belgaum, and Dr. Rashmi Suri, Assistant Professor, Department of Anesthesiology and Critical Care, KSECDE Medical Academy, Nitte, deemed to be university. She has a PDCC in cardiac anesthesia. And the presenters for the same will be Dr. Shabanti Jana and Dr. Srinivasa Reddy, junior residents from SSIMS and RC, Davangere. Welcome, sir, madam, and the residents. Once again, warm welcome to all who have joined us with this webinar today. And now I call upon Dr. Muralidhar Kanchi for the masterclass. Thank you.
Over to you, sir.
Thank you. Thank you very much for that kind introduction. And it's an absolute delight for me to participate in the Nitte Anaesthesiology educational series. And I would like to thank Dr. Shripad and Dr. Sumalata Shetty for the invitation. And in the next 30 minutes or so, I will be dealing with the pathophysiology of valvular heart disease. Can you hear me?
Yes, sir, we can hear you clearly.
And my slide is visible?
Yes, I
Yes,
can
sir.
my slide up.
Now it's a beauty of beating, sir.
Thank you. Thank you so much. As you all of you know that the incidence of valvular heart disease is increasing with age, especially in the Western world. At a rate of the incidence, about 13% of all adults over the age of 75 have moderate to severe valvular heart disease, especially in the form of aortic stenosis or mitral regurgitation. But in this part of the world, rheumatic heart disease being rampant, We have heart disease, acquired heart disease in the younger population, and rheumatic heart disease is the commonest cause for heart ailment in these parts of the world. If you look at the number of deaths which occur in a world population of about 8 billion, as of today, the world population is about 8 billion and there are 60 million deaths every year, out of which about 30% of the deaths are because of cardiovascular diseases. And hence we need to focus our attention to this. And if patients have heart disease and come for cardiac, non-cardiac surgery, we need to know what is the pathophysiology, what are the investigations we need to do, what is the preoperative and pre-anesthetic preparation, what is the choice of anesthetic agents, and how to manage the anesthesia, and what are the goals of anesthesia in each of these valvular heart diseases. If we look at the heart, there are 4 valves. The pulmonary valve, which has the anterior cusp, right cusp, and the left cusp. And we have the aortic valve, which has the left cusp, right cusp, and the non-coronary cusp. This is the non-coronary cusp. And we have the mitral valve with the anterior leaflet and the posterior leaflet. And we have the tricuspid valve with anterior leaflet, septal leaflet, and posterior leaflet. So if you note, only the mitral valve has 2 leaflets. Other 3 valves have 3 leaflets. The first thing we need to know when you talk about valvular heart disease or heart disease in general is that we should know what is the New York Heart Association functional classification. It is relatively simple to remember because if you remember these 3 words, limitation of physical activity, if you remember these 4 words, you can just classify them into no limitation, which is class 1, slight limitation of physical activity, which is class 2, and marked limitation of physical activity, which is class 3. And class 4 is inability to carry out any physical activity without discomfort, or the patients are symptomatic at rest. This is the New York Heart Association functional classification, which is very important when we describe the functional status of a patient. And also to this, you can add METs, that is metabolic equivalence, especially when you're talking about cardiac patients coming for non-cardiac surgery, because we depend upon the functional status measured as metabolic equivalence. As long as the functional capacity is more than 4 METs, we consider that patient to be reasonably fit for surgery without any further investigations from the cardiac point of view. The second thing which we would like to know is what is the normal pressure volume relationship in a normal heart. For example, if you take this picture, we have a cardiac cycle represented in time here and pressure in the vertical axis. If you look at the time factor, each cardiac cycle lasts for about 0.8 seconds. So what is important for us to know is that the electrical events, that is the ECG, precede the mechanical events. First important thing I would like to emphasize is that the electrical event precedes the mechanical events. And here there are 2 curves. This is the left ventricular volume and the left ventricular pressure. So during systole, which lasts up for about 0.3 seconds, there is a rapid increase in the left ventricular pressure, which makes the aortic valve open and the blood is ejected into the aorta for systemic perfusion. And the pressure volume loop looks like this. Here what we have done is we have put the volume on the horizontal axis and the pressure on the vertical axis. This is also important for us to understand the pathophysiological mechanisms involved in valvular heart disease. This is a pressure volume loop in a normal heart. If you look at this pressure volume loop, we have the diastole here. This part is the diastole. This is the isovolumetric contraction phase. This is the ejection phase, and this is the isovolumetric relaxation phase. So the correspondingly, the mitral valve opens for the diastole to occur, and the mitral valve closes for the isovolumetric contraction phase to occur. And once the left ventricular pressure is greater than the aortic pressure, the aortic valve is opened and the blood is ejected into the aorta. And then as the ventricular ejection ceases, the aortic pressure exceeds the left ventricular pressure and the aortic valve gets closed, and we enter the isovolumetric relaxation phase. Actually, this is also a part of the diastole. The left ventricle is relaxing here, but both the valves are closed. The aortic valve is closed, mitral valve is closed, but there is a decrease in the left ventricular pressure. There's no change in the volume here. That's why it's called as isovolumetric relaxation phase. Once the left ventricular pressure falls below the left atrial pressure, the mitral valve opens and the diastole, actual diastole, that is the filling up of the left ventricle, takes place. Coming to the rheumatic heart disease, we need to deal with rheumatic heart disease a bit, not in great detail, but a little bit, because that is the commonest form of heart disease we encounter in this subcontinent. The rheumatic heart disease is as a result of beta hemolytic streptococcal infection, usually in the form of a sore throat, which elicits a non-suppurative inflammatory fever, like an inflammatory condition called rheumatic fever, which can be diagnosed using the major criteria or minor criteria. This is the famous Jones criteria, which is usually described, but this has been modified recently by the physician from Jayadeva Institute of Cardiac Sciences, Dr. Vijayalakshmi, has included echocardiographic parameters in that. As far as we are concerned, we should know what are the major criteria and minor criteria. The major criteria are the carditis, polyarthritis, Sydenham's chorea, erythema marginatum, and subcutaneous nodules. And the minor criteria include fever, arthralgia, increased ESR, increased CRP or ASO titers, prolonged PR interval, and leukocytosis. If you have one major criteria and two minor criteria, it can be labeled as rheumatic fever. Or if you have two major criteria, that should be enough for us to label that febrile illness as rheumatic fever. It so happens that as much as 25% of the patients do not recall that they have had rheumatic fever, because the patient has some sore throat, some body pains, maybe some joint pains, which is not recognized. And then in 25% of the patients with rheumatic heart disease, the history of rheumatic fever may be lacking. Nevertheless, rheumatic fever is the commonest cause for heart disease in this part of the world. Coming to the first lesion, we have what we have shown here is the mitral stenosis. When the mitral valve is stenosed, the normal mitral valve orifice or the mitral valve area is 4 to 6 square centimeters. Normal mitral valve area is 4 to 6 square centimeters. And if it comes below 2.5 square centimeters, the patient becomes symptomatic. Till it becomes 2.5, most of the time, these patients remain asymptomatic. But once the mitral valve area comes to less than 2.5 square centimeters, the patients start to exhibit these symptoms. Typically, In a mitral stenosis patient with pure mitral stenosis, we have a diastolic rumbling murmur, which is best heard in the apex, at the apex, and it is best heard with the bell of the stethoscope because it is low pitched, and with the patient turned to the left side, and in the expiration. One thing we should remember is that left-sided murmurs are better heard during expiration, whereas the right-sided murmurs are better heard in the inspiration. This is important for us to note because if the diastolic murmur can occur with tricuspid stenosis as well, but in tricuspid stenosis, the murmur is more prominent during inspiratory phase of the respiratory cycle. This is how we have a differential diagnosis of a diastolic rumbling murmur, whether it is tricuspid stenosis or mitral stenosis. Mitral stenosis is best heard during expiratory phase because of the fact that the stroke volume during inspiration is greater on the right side as compared to the left side, and on the left side it is the expiration where the stroke volume is higher. And if you note here, there is pre-systolic accentuation. This is the first heart sound and the second heart sound, first heart sound, second heart sound. And this murmur gets accentuated during pre-systolic phase because of the fact that the left atrium contracts vigorously to be able to fill up the left ventricle because there is an obstruction at the mitral valve level. The left atrium has to contract vigorously to pump in the blood to maintain the LV stroke volume and the LV preload. So there is pre-systolic accentuation. And please note that this pre-systolic accentuation will disappear with the onset of atrial fibrillation because the atrium is no longer contracting in atrial fibrillation. So as I said, the normal mitral valve area is 4 to 6 square centimeters. And what is remarkable or most marked feature of mitral stenosis is the presence of atrioventricular pressure gradient. That is, the atrial pressure during diastole is greater than the ventricular pressure for the most of the diastolic period. Normally, the pressure gradient between the left atrium and the left ventricle during diastole is minimal, or especially during diastasis, that the middle portion of the diastole, it is 0. But in this patient, the atrioventricular pressure gradient is markedly increased. And this is a hallmark of mitral stenosis. In fact, depending upon the mean gradient across the mitral valve, we can classify the mitral stenosis into mild, moderate, or severe. If the gradient is less than 5 millimeters of mercury, it is mild. 5 to 10 millimeters of mercury, it's moderate. More than 10 millimeters of mercury, it is severe. Easy to remember, 5, 10, and more than 10. This is the mean gradient. Please note that this is not peak gradient, it's the mean gradient across the mitral valve. Less than 5, 5 to 10, more than 10. This is associated with increase in the left atrial pressure, which is transmitted backwards into the pulmonary venous system, pulmonary capillaries, and pulmonary artery. And if the LAP is increased acutely, there may be pulmonary edema. And chronic elevation of the pulmonary artery pressure leads to pulmonary hypertension, which in turn leads to right ventricular hypertrophy, tricuspid annular dilatation, right ventricular dilatation, right ventricular failure, associated with increased jugular venous pressure, ascites, hepatomegaly, and pedal edema. This is the sequence of events. That is, with the increase in the left atrial pressure, backward transmission of the pressure to the venous system, pulmonary venous system, pulmonary capillaries, pulmonary artery, increased pulmonary arterial pressure, right ventricular dilatation, tricuspid annular dilatation, increase in the right atrial pressure and the right-sided failure. All these are happen in a sequence, making the patient be a case of congestive cardiac failure. Not only the left heart is not doing very well, even the right heart suffers because of the chronic rheumatic mitral stenosis. This is a schematic representation of the left ventricular, aortic, and left atrial pressures. This is the left ventricular pressure in black and the aortic pressure in broken lines. And this is the diastolic phase of the cardiac cycle. And the systole starts somewhere at the top of the R wave. As we already said that the mechanical events follow the electrical events. So the actual systole starts from the top of the R wave. So this is the diastole with the mild mitral stenosis. The left atrial pressure is increased, but with severe stenosis, left atrial pressure is chronically elevated. Normal left atrial pressure is about 6 to 12 millimeters of mercury. Normal left atrial pressure is 6 to 12 millimeters of mercury. And if we look at the pressure volume loop, which we alluded to in the previous slide, in mitral stenosis, the pressure volume loop here is shown in green is the mitral stenosis, where you see that the pressure volume loop is shifted towards the left and down, which means that the stroke volume is diminished. This is the normal stroke volume, which is larger than what is seen in mitral stenosis with diminished stroke volume. And what you can also see that the left ventricular end-diastolic pressure is less because left ventricle is not filling fully, and left ventricular end-diastolic pressure also is less as compared to normal in these patients. So there is underfilling of the left ventricle. There is underfilling of the left ventricle as a result of impediment to the left ventricular filling because of the mitral stenosis. If you look at the mitral valve area, we already said that the normal valve area is 4 to 6 square centimeters. With mild mitral stenosis, the parameters like left atrial pressure, pulmonary artery pressure, cardiac output are normal at rest. But with exercise, they increase. And with further reduction in the mitral valve area to 1.1 to 1.5 square centimeters, even at rest, the left atrial pressure is increased, PA pressure is increased, cardiac output is maintained. But with exercise, there is further elevation in the left atrial pressure and the pulmonary artery pressure. But with further reduction in the mitral valve area to 0.6 to 1 square centimeters, the left atrial pressure, the pulmonary artery pressure is elevated even at rest, and the cardiac output is decreased. And these patients are having critical mitral stenosis, who may be having paroxysmal nocturnal dyspnea and orthopnea. Paroxysmal, the orthopnea is a condition where when the patient lies flat, he becomes dyspneic because of the shift of blood volume from the peripheral tissues into the intrathoracic compartment, leading to pulmonary congestion. And patient, once he sits up, he or she feels better. This is orthopnea. And paroxysmal nocturnal dyspnea is the similar thing occurring during sleep. And these two conditions represent that the patient is already in NYHA class 4, and the mitral valve area is likely to be less than 1 square centimeter. Coming to investigations, we'll look at the ECG, X-ray, and echocardiography. In the ECG, what we notice is the bifid P waves in lead 1, V1, and this will be this may be termed as P mitral, especially this one. You can see bifid P wave here. Because of the left atrial enlargement, the right atrial complex and left atrial complex slightly separate out, becoming a bifid P wave. This is typical of mitral stenosis. And in patients with atrial fibrillation, you see irregular pulse. This is the commonest cause for atrial fibrillation. If we want to know what are the causes for atrial fibrillation, rheumatic heart disease with mitral stenosis or mitral regurgitation, or you can say that in general, mitral valvular heart disease is the commonest cause for atrial fibrillation, especially in this part of the world. The other causes for atrial fibrillation are thyrotoxicosis, ischemic heart disease, diastolic dysfunction, pericardial disease, and sometimes severe pulmonary disease. If you look at the X-ray, there is straightening of the left border. And in a typical case of mitral valve disease, mitral stenosis, there is pulmonary congestion with redistribution of blood flow to the upper lung zones and the formation of curly B lines, which are horizontal lines seen at the bases of the lungs because of the lymphatic congestion. In patients who have right-sided failure, you may see some sort of cardiomegaly, but typical mitral stenosis, the heart is not enlarged unless there is right-sided involvement leading to right-sided ventricular hypertrophy and right-sided failure. Coming to the echocardiography, 4 things we should remember is that the mitral valve leaflets are thickened. First thing is mitral valve leaflets are thickened. Second is the mobility of the mitral valve leaflet is restricted. They do not move freely. Third thing is they become calcified. And fourthly, there is subvalvular fusion. These are the 4 pathological features of the mitral valve apparatus as such: thickening, restriction of the movements, calcification, and subvalvular fusion. And the secondary effects of mitral stenosis include left atrial enlargement, right ventricular hypertrophy, and pulmonary arterial hypertension. This is how the echocardiography looks, especially when you do the transesophageal echocardiography. We have the right atrium, right ventricle, the tricuspid valve in between, left atrium, left ventricle, and the mitral valve here. The mitral valve, you can see that the posterior mitral leaflet is totally fixed. It is not moving. And the tips of the valves are calcified. And you can see that the valve is not opening. There is hardly any opening. And what is markedly seen is that there is spontaneous echo contract in the left atrium, which indicates the stasis of blood in the left atrium. A bit of stasis is occurring as a result of rollo formation of the RBCs because blood is not freely moving into the left ventricle. And this is a precursor of formation of thrombi. Yes, usually the left thrombi form in the left atrial appendage, which is somewhere here. Coming to grading of mitral stenosis, we already mentioned that mean pressure gradient across the mitral valve less than 5 is mild, 5 to 10 is moderate, more than 10 millimeters of mercury is severe. Please note that we are talking about mean pressure gradients. Mitral valve area less than 1 is severe, 1 to 1.5 square centimeters is moderate, 1.5 to 2.5 square centimeters is mild. How do you treat? What are the symptomatology? Usually there is dyspnea on exertion, and this progressively worsens. And with the onset of atrial fibrillation, there is worsening of the symptomatology, especially in terms of heart failure. And some patients may develop atypical chest pain, and some of them may also manifest hemoptysis, that is blood tinged sputum. If there is acute increase in the left atrial pressure, for example, somebody has exerted or become pregnant or had fever or anxiety, any of the conditions which increase the heart rate may push these patients to heart failure. And these patients tolerate tachycardia very poorly. Hence, we need to decrease the heart rate, maybe using beta-adrenergic blockers. If there is atrial fibrillation, we need to use digoxin to control the ventricular rate, diuretics to relieve pulmonary congestion, anticoagulants if the patients have atrial fibrillation, and the percutaneous balloon valvuloplasty can be done if the valve is pliable and the mobility is not as bad as we saw in the previous case. That is, the valve is somewhat supple, but surgically we need to consider open valvulotomy or repair or replacement depending upon the individual case. Coming to hemodynamic goals here, first thing is avoid tachycardia. Anything which increases the heart rate must be avoided, whether it is anxiety or pain or the drugs like ketamine, atropine, pancuronium must be avoided. Normal sinus rhythm must be maintained because we need the atrial kick mechanism to fill the left ventricle. The pulmonary vascular resistance should be maintained or decreased if it is already increased. We have to maintain the preload cautiously, because if you increase preload suddenly, because of the narrowed orifice, the blood may not be able to pass through the mitral valve into the left ventricle, pushing the patient to pulmonary edema then and there. So we have to maintain the preload, do not decrease it, which means that we have to be extremely cautious when we give fluids. We have to give fluids, but cautiously looking for signs of pulmonary congestion, putting a stethoscope at the base of the chest to look for any rails to detect early impending pulmonary edema. This is about mitral stenosis. I have not gone into too much of details, but I just wanted to give you the bird's eye view, which most important points from physiological point of view. Coming to mitral regurgitation, mitral regurgitation may result from a variety of disease process. This mitral valve, as you know, consists of the mitral valve leaflets, the annulus, then the adjacent the caudate tendinae, papillary muscle, and adjacent myocardium. There are 5 structures involved in mitral valve: the mitral valve leaflets, the annulus, caudate tendinae, papillary muscle, and the adjacent myocardium. So the problem with any of these 5 structures, one or more of these structures, may lead to mitral regurgitation. For example, the mitral valve leaflet may be normal, but if the annulus is dilated because of ventricular dilatation, there will be mitral regurgitation. The mitral valve leaflets may not be able to coapt, though they are normal in function and structure. Because the annulus is dilated, the valve leaflets cannot coapt during systolic phase of the cardiac contraction. The causes of mitral regurgitation are mentioned here. From our point of view, the important reasons are rheumatic heart disease, ischemic heart disease, and some of the degenerative diseases like mitral valve prolapse and myxomatous degeneration of the mitral valve, infective endocarditis, some of the usual causes for mitral regurgitation. If you look at the pressure volume loop, what is remarkable here is that the great increase in the LV end-diastolic volume. End-diastolic volume of the LV is increased. This is the LV volume here. Normally it should be 120 ml. It is gone about, in this graphic representation, it is showing 200 ml, and there is hardly any isovolumetric contraction phase. Because as soon as the left ventricle starts to contract, the blood is going to the left atrium because the mitral valve is incompetent, and hence you do not see a typical isovolumetric contraction phase. And after some time, the aortic valve opens and there is ejection in the left, the aorta, and then the subsequent events of cardiac cycle follow. The mechanisms of mitral valve, as I said, there are 3 great mechanisms. One is the with normal left ventricular, normal papillary, normal mitral valve leaflet motion. Here the annulus is dilated, but the valves are normal. This happens in patients who have ventricular dilatation. The second mechanism is excessive motion. Suppose a valve leaflet is prolapsing. This is called excessive motion, and there is a mitral valve regurgitation as a result of failure of coaptation of the leaflets. The third mechanism is restricted leaflet mobility. Here, especially in rheumatic heart disease and in some patients who have ischemic heart disease, the leaflet becomes fixed because of calcification or thickening, and this will again prevent the coaptation of leaflet, leading to mitral regurgitation. The typical murmur in these cases is a pansystolic murmur, which is heard well in the apex, which is radiating towards the back, and during expiration, better heard during expiration. All the left-sided murmurs are heard better during expiration. If you look at the ECG, we have the left ventricular hypertrophy. So when do you call left ventricular hypertrophy? When the sum of S wave and the R wave, S wave in V1 and R wave in V4 and V5 are greater than 35 millimeters. These are the voltage criteria for labeling it as a left ventricular hypertrophy based on ECG. X-ray will show heart enlargement, and if the left atrium is enlarged, you will see the angle of division of the bronchi, from the carina, main bronchi, is increased, and there is left atrial enlargement here. And in patients with right heart failure, right atrium may be enlarged. And this is shown here, right atrial enlargement. You can also see a prosthetic valve here. And in the echocardiography, there is a jet going into the left atrium during heart contraction, which should not normally happen. This is the regurgitation jet. The grading of mitral regurgitation depends upon the jet area. If it is more than 8 square centimeters, regurgitant volume greater than 60 ml, regurgitant fraction greater than 55 ml, regurgitant orifice area greater than 0.4 square centimeters, vena contracta of 0.7 centimeters, qualifies this level of regurgitation as severe regurgitation. What are the hemodynamic goals in mitral regurgitation? We have to maintain slight tachycardia towards the, upper normal range of heart rate, 80 to 90 beats per minute, because we know that the forward flow is better when the heart rate is slightly increased. Avoid increase in systemic vascular resistance. You would actually decrease the systemic vascular resistance so that there is no impediment to left ventricular ejection. Maintain contractility and maintain preload. Coming to the third valvular lesion, we have the aortic regurgitation. Here, the aortic regurgitation can occur as a result of problem with the valve leaflets or aortic root disease. There is a problem with the aortic annulus. So the valve leaflets are not able to coapt. So there is regurgitation, or there may be defect in the valve leaflets. There are several reasons for the aortic valve regurgitation. And if you look at the pressure volume loop, especially the chronic aortic regurgitation, the end-diastolic volume is very much increased. In this diagram, it is showing about 350 ml. Normal LV end-diastolic volume is about 120. It is more than 3 times, which means that left ventricle is actually dilated. And again, there is hardly any isovolumetric contraction phase. And if you look at the blood pressure, the diastolic pressure is low because of the incompetent aortic valve. The blood is coming back into the heart, and there is no pressure during diastole. During diastole, the blood is going back to the heart. because the aortic valve is not competent. This results in decreased diastolic pressure, decreased myocardial oxygen supply, increased myocardial oxygen consumption, increase in the left ventricle end-diastolic pressure leading to dyspnea, and there may be associated myocardial ischemia leading to left ventricular failure. One important thing we should remember is that in patients with aortic regurgitation, they may be actually little better when they are doing some work rather than when they are resting increased. For example, a patient has a resting heart rate of 70, and when he's doing some work, if it goes up to 90, he actually feels better than when he is resting, which means that the forward flow is better with slight tachycardia, which is a point which we should take into consideration when we give anesthesia for these patients. There is an early diastolic murmur, which is a decrescendo type of murmur, which is again better heard in the aortic area with bell of a stethoscope during expiration. The X-ray will show cardiomegaly. And in this picture, what we are showing is the aortic valve long axis view. You can see that the aortic root is dilated, aortic annulus is dilated, and the leaflets are not coapting. They're not coming and touching each other. Normally, the aortic valve leaflets touch each other, and in this image, you must see them as a sort of namaste sign. When you put both the hands together, it should look like that. That is the namaste sign. And you can see that there's a gap between the two leaflets, so the blood will leak into the left ventricle during diastole. Coming to the grading, the jet width to LV width, if you can make a ratio, if it is more than 0.65, vena contracta, that is the narrowest width of the jet, is more than 0.6. The regurgitant volume greater than 60, regurgitant fraction greater than 50%, regurgitant orifice area greater than 0.3 square centimeters qualifies that condition to be called as severe aortic regurgitation. Coming to the pressure, that pressure volume, we have already done it. Those hemodynamic goals are similar to that of mitral regurgitation. Maintain heart rate at about 90, decrease the SVR, maintain contractility, and maintain preload. Coming to aortic stenosis, the pressure volume loop is shown here. The normal loop is here, and the aortic stenosis pressure volume loop is shown in the green. What is remarkable is there is extraordinary increase in the left ventricular pressure during systole. If this is the normal systolic pressure in the left ventricle, about 120, in these patients, left ventricular pressure is about, depending upon the severity of the disease, it may be, in this picture, it is showing us 240. So this is the pressure gradient. Especially, I'll show you another picture where you can see the pressure gradient across the aortic valve, which is seen during systole. What is the etiology? The bicuspid aortic valve by far is the commonest lesion. In fact, 1 to 2% of the people are born with bicuspid aortic valve, and this manifests after 40 years of age, and hence aortic valve disease, though it's congenital in origin, it's not classified into congenital lesions. The second commonest lesion is the age-related degeneration of the valve, which causes calcification. And in this part of the world, we have the rheumatic valve disease as another causative factor for aortic stenosis. This is the normal valve. 3 leaflets are seen here. And this is the bicuspid valve. There are only 2 leaflets. 1 to 2% of normal population have this. And this becomes manifest only when the person is 40 years or more. And this is a rheumatic heart disease where there is commissural fusion. You can see the commissures are fused, and this is the degenerative calcific aortic stenosis. Coming to pathophysiology, there is left ventricular outflow tract obstruction leading to increased LV systolic pressure. There is a marked left ventricular hypertrophy, increase in myocardial oxygen consumption. There is diastolic dysfunction. Myocardial oxygen supply is decreased in the face of increased myocardial oxygen demand. All this leading to left ventricular failure. And the three cardinal symptoms of aortic stenosis is chest pain, breathlessness, and syncope. I'm repeating it: syncope, breathlessness, and angina or chest pain. These are the three cardinal symptoms. And if the patient, the aortic stenosis, exhibit one of these symptoms, the natural history says that they will have a death within 2 to 5 years. So these patients must be addressed fairly quickly. Otherwise, these patients will have a natural death. If you look at the auscultatory finding, there is a ejection systolic murmur, which is best heard in the aortic area, and it is transmitted to the carotids. Please note that this pressure, the murmur is radiating to the neck in the carotid arteries. And what I was talking to you about the pressure gradient is this is the aortic pressure. This is the left ventricular pressure. This difference is almost zero normally, but here it is severely increased because of the aortic stenosis. All the pressure which is generated in the left ventricle is not getting transmitted to the aorta because of the narrow orifice, and the heart is trying to pump hard to pump blood through the narrow aortic orifice, which makes the systolic phase longer, and there is a gradual or slow rise in the pulse and low volume pulse, which manifests clinically as pulses tardus and parvus. The normal aortic valve area is 3 to 4 square centimeters, easy to remember. Normal aortic valve area is 3 to 4 square centimeters. And if it becomes less than 2.5 square centimeters, then the manifestations or symptoms may start. And there is a gradient between the LV and aorta during systole, which I showed it in the last picture. There is a concentric left ventricular hypertrophy in comparison with eccentric LV hypertrophy, which occurs with mitral regurgitation and aortic regurgitation. LV end diastolic pressure is increased. There is stiffness of the left ventricle, and the left ventricular compliance is decreased. Oxygen demand is increased, myocardial oxygen supply is decreased, and atrial contribution to the left ventricular filling is very important component. Normally it is about 20%, but in these patients it will be as much as 40%, which means that the atrial contribution to the left ventricular filling must be maintained at all costs. And because of the blood is going through the narrow orifice of the aortic stenosis, there may be venturi effect, which means that beyond the aortic stenosis, that beyond the aortic valve, there is pressure drop, which may suck the blood into the aorta from the coronaries. Just remember this. This is the venturi effect, which may predispose the patient to sudden cardiac death. What are the symptoms? I said 3 cardinal signs. I am repeating again: angina pectoris, syncope, and breathlessness or congestive heart failure. There is pansystolic murmur or ejection systolic murmur. It's not pansystolic murmur, it is ejection crescendo decrescendo murmur, which is heard in the aortic position conducted to the carotids. If you look at the ECG, there is left ventricular hypertrophy with strain pattern. ST segment is depressed and T wave is inverted. Usually this T wave inversion is symmetrical in nature. The X-ray shows the unfolding or the post-stenotic dilatation of the aorta in this manner. And in the echocardiography, this is a normal aortic valve with 3 leaflets. This is a normal aortic valve. The left coronary cusp, the right coronary cusp and the non-coronary cusp, and the left main stem artery is arising from the left main coronary sinus. Here you can see it. But in these patients, the aortic valve is calcified and not opening fully. And in the long axis view, you can see so much of calcium is there in the aortic valve. And the severity of aortic stenosis depends upon the jet velocity more than 4 meters per second, or the mean pressure greater than 40 millimeters of mercury, valve area less than 1 square centimeters, qualifies this to be called as severe aortic stenosis. Patients with moderate to severe aortic stenosis have a fixed low output state, and hence they cannot tolerate any decrease in the systemic vascular resistance. What are the goals of management? Preload must be maintained or increased. Here, just note that afterload must be maintained or even increased to maintain the coronary perfusion. If the afterload decreases in the face of a hypertrophied left ventricle, the heart just will not be able to tolerate that. There will be acute ischemic cardiac arrest. Maintain sinus rhythm because atrial contribution to LV filling is mandatory. Avoid hypotension, bradycardia, and tachycardia. These patients are very difficult to manage, especially if they have severe aortic stenosis. They do not tolerate hypotension, tachycardia, or bradycardia. You have to maintain them within a narrow physiological limits in terms of cardiovascular status. What are the complications in valvular heart disease? Pulmonary edema, left heart failure, right ventricular dysfunction, right heart failure, atrial fibrillation or any other type of arrhythmia, increase in the pulmonary artery pressure, systemic embolism, especially in stenotic lesions, mitral stenosis, pulmonary hypertension, pulmonary embolism, bronchitis, hemoptysis. Is the normal heart sound? Aortic insufficiency, there is early diastolic murmur. Aortic stenosis, there is a systolic murmur, ejection systolic murmur. Mitral regurgitation, we have pansystolic murmur. Mitral stenosis, we have a mid-diastolic rumbling murmur. And if patient come for non-cardiac surgery, you look into the NYHA classification and see how they fit into the revised cardiac risk index, and then decide upon the risk and then further manage the case depending upon the meds. And the goals of management I already highlighted, depends upon the NYH status and the valvular area in case of stenosis, and the regurgitant fraction in case of regurgitant lesions. I think with this, I would like to conclude my talk saying that understanding pathophysiology of valvular heart disease is important to be able to safely manage them when they are undergoing non-cardiac surgery. If the valvular lesion is severe enough, we might have to consider addressing the valvular lesion first and then subjecting the patient to a non-cardiac procedure, depending upon the circumstances and the decision of the team involving cardiologist, echocardiographer, the surgeon involved, the anesthesiologist, and the intensive care physicians. Thank you so much for this opportunity. If there are any questions, I'll be happy to take them on.
Thank you, sir. It was a fantastic presentation with the nice slides that we could understand what was going on.
Thank you. Thank you so much.
As usual, I should say.
Thank you.
Any questions? Please come put your questions. Either you can directly ask or you can put in the chat.
Yes, yes. Any question is fine. And also, I would like to point out that in case of stenosis, if it is severe stenosis, please go for GA. If it is regurgitation, the neuroaxial blockade can be therapeutic advantage because you are reducing the SVR with the central neuroaxial blockade. So the central neuroaxial blockade may be suitable for patients with regurgitant lesions. When you talk about mild stenotic lesions, graded epidural may be instituted if the situation warrants it. But if the patient has severe stenotic lesion and the non-cardiac surgery is mandatory, general anesthesia with endotracheal intubation and monitoring of the arterial pressure directly will be advisable, especially if it's a major surgery. Thank you so much.
Thank you, sir. If
Sir,
there
good
are
afternoon,
any
sir.
questions.
Yes, yes, yes.
Sir, good afternoon, sir.
Yes.
Wonderful. There are no words to explain your talk. So coming to my question,
Yes.
I see more of mitral valve prolapse cases, mild to moderate,
Yes.
than the real like MS, MR, ASAR, something like that. So usually they go uneventfully. I mean, what we have seen. Would you
Yes.
like to throw some light on it? Because I see more of MVPs than the real stenotic and regurgitant valves here.
See, in general,
Sir.
please don't quote me. In general, if it's a regurgitant lesion, they tolerate anesthesia well because the grade of regurgitation actually comes down with anesthesia. When you're giving anesthesia, there is sympathetic depression of sympathetic system, which decreases the SVR, which is beneficial for these patients. If we are giving a good quality anesthesia, actually the hemodynamics increase. In fact, it's a dictum in cardiac anesthesia that the grade of MR comes down with general anesthesia by 1 grade. If it is grade 3 MR, it becomes grade 2 with anesthesia. So this is one of the reasons why these patients may be behaving well under anesthetic conditions. But having said that, one downside of these lesions is that, especially regurgitant lesions, is that the ejection fraction is fallacious. Please note this. The left ventricular ejection fraction, if you look into the echocardiography report, if it says 55 or 50, this means that patient's LV is already down. Because of in the ejection fraction, what we are looking at is the end systolic volume and end diastolic volume.
Yes.
And because of the low pressure chamber in the LA, because of the incompetent valve, when the heart contracts, some of the volume goes to the LA and it is emptying well. So actually it's going to the LA and we are saying that EF is good, but the EF may not be actually, in fact, the LV EF is overestimated in regurgitant lesions.
Okay.
This has to be kept in mind.
Rightly said, sir. We see physicians giving us, cardiologists giving us near normal EFs in most of these mitral valve prolapse.
Yeah, it will be normal. It will be 50 or 60, though the LV function may be depressed. Because LV is pumping to the low pressure chamber, which is the left atrium. Some of the blood is going stroke volume from the left ventricle is not only going to the aorta, but also going to the left atrium because of the incompetent valve. So when you are estimating ejection fraction, we are only looking at the LV end diastolic volume and LV end systolic volume. Where it is going, we are not seeing. So LV EF, as measured by the echocardiography, may look good in the face of poor LV. Thank you.
Thank you, sir.
Thank you, sir.
Sir, there is a question in the chat box.
Yes.
Dr. Alvina Amita from Mumbai has asked a question.
Yes.
What
Sir.
is the importance of aortic sclerosis, which we see very often in geriatric patients?
Very nice question. Thank you for that. Aortic sclerosis is degenerative disease of the aortic valve. There is some sort of disease process going on there, but the gradients are not more than gradients across the aortic valve is not great enough to label it as aortic stenosis, but given time, these patients may progress to mild aortic stenosis. In the presence of aortic sclerosis, I don't think we need to bother about the aortic valve per se, because there is not much of a gradient, but we should concentrate on other comorbidities in a geriatric patient. The patient may have aortic or the arterial stiffness and increased pulse pressure. Those other pathophysiological changes will be present. From aortic valve itself, there should not be any problems. Thank you for that question.
Thank you, sir. Thanks, Dr. Alvina, for the question.
Thank you, sir. If there are any questions, please put it in the chat so we can take it up later. Now we'll go on to the case discussion. Mitral stenosis patient coming for incidental surgery. We have Dr. Shrabanti Jana and Dr. Srinivasa Reddy, junior residents of SSIMS and RC Davangere. Our moderators are Dr. Rajesh Mane, Professor and HOD of Anaesthesiology, JNMC, Belgaum, and Dr. Rashmi Suri from the Department of Anaesthesiology and Critical Care, KSAG Medical Academy. Over to you, sir, Dr. Rajesh Mane and Dr. Rashmi.
Okay, ma'am.
Yeah, over to
Dr.
you.
Rajesh, we are not able to hear you. Can you please unmute?
Hello, yeah. Can you
Yes,
hear me?
yes. Good afternoon.
Yes, Dr. Rajesh, we can hear you.
Yeah, and I'd like to thank Dr. Sripad and his team at Shema for inviting me for this excellent webinar. And I congratulate them for beginning such a wonderful series, education series, which I hope will be very much helpful to not only the postgraduates, but the budding anesthesiologists all over. We had an excellent talk by Dr. Muralidhar, very much in-depth insight into the valvular heart disease. We'll go ahead with the discussion. Yeah, Dr. Rashmi, if you want to talk anything.
I think we'll go ahead with the discussion.
Good afternoon, sir, and good afternoon, ma'am. Starting with the history, my patient is Mrs. Lakshmi Devi, 45-year-old female, hailing from Rane Venur. She's a homemaker by occupation.
Shrabanti, there's some echo in your side. I'm sorry. Disturbance on your side. Probably because you're not using the earphone.
Homemaker by occupation, belonging to lower middle class. She came with chief complaints of
Sorry, Shrabanti. Dr. Soundarya, could you keep your mute yourself, please? Dr. Shrabanti, carry on.
She has come with chief complaints of irregular menstrual cycles and excessive bleeding since the past 1 year. She has complaints of dyspnea on exertion since the past 6 months and palpitations since the past 6 months. History of presenting illness. Patient was apparently in her usual state of health 1 year back when she started having irregular menstrual cycles with excessive bleeding. Her cycle length is 20 to 25 days with bleeding of 7 to 8 days with passage of clot since the last 1 month. She consulted a gynecologist and was told she has a mass in her uterus which requires surgical removal. There's no associated pain or mass per abdomen. There's no bowel and bladder complaints, and there's no history of weight loss. She also complains of dyspnea on exertion since the past 6 months. It is insidious in onset and progressive. Earlier, she was able to do her household activities and only felt breathless on doing more than ordinary activity. But now she feels breathless even doing her usual household activities. The breathlessness is aggravated on physical activity and relieved on rest, and there's no history of breathlessness immediately on lying down or after sleeping for a few hours. There is also no history of cough, hemoptysis, or wheezing. She also gives history of palpitation since past 6 months. It is acute in onset, intermittent, and relieves spontaneously. There are no aggravating or relieving factors, and it's not associated with syncope or chest pain. There is also no history of fever, rash, joint pain, or involuntary movements of the limbs. No history of painful fingertips. No history of pedal edema, ascites, pain in the right upper quadrant. No history of hoarseness of voice or difficulty in swallowing. The past history. There is history of recurrent episodes of fever with sore throat and arthralgia in childhood. She was hospitalized and told to have a heart disease and advised monthly injections. The patient stopped after 4 years. She does not have any other comorbidities, and there is no history of any other drug intake. Patient underwent tubectomy at 25 years of age under spinal anesthesia with uneventful recovery. Personal history, diet mixed, appetite is normal, bowel and bladder habits are normal, no addictions. Menstrual history, her last menstrual period was 1st March 2022. Irregular cycles 20 to 25 days, which last 7 to 8 days. There is history of passage of clots and no foul smelling discharge or spotting is present. Obstetric history, para 2, lipo 2. Both were full-term normal vaginal deliveries at 25 and 30. Family history, there's no similar complaints in other family members and no history of any other chronic illnesses. The summary, a 45-year-old female patient presenting with dyspnea on exertion and palpitations in the past 6 months. She has irregular menstrual cycles with excessive bleeding since the past 1 year. And there's history of recurrent fever with sore throat in childhood, which required hospital admission and intramuscular injections every month.
Coming to the general physical examination, patient is examined in supine position. Patient is conscious and sitting comfortably in bed, well oriented to time, place, and person. She is moderately built and poorly nourished. Height, coming to the height of the patient, 165 centimeters and weight of 50 kg, BMI of 18.3. And general physical examination, pallor was present, pedal edema, bilateral pitting type of pedal edema was seen, and pickle, it was no icterus, cyanosis, clubbing, and lymphadenopathy. Vital signs, temperature was afebrile, pulse was 70 beats per minute, felt in right radial artery, and regular rhythm, normal in volume and character, normal condition of the vessel wall, and no radio-radial or no radio-femoral delay. All peripheral pulses were felt. Respiratory rate was 18 beats per minute, 18 cycles per minute, and a regular thoraco-abdominal type of breathing. BP was 110/70 millimeter mercury. It was checked in right upper limb in supine position. JVP was elevated, and height of the JVP was 8 centimeters. Coming to the airway examination, teeth was normal and no loose teeth. Mouth opening was more than 2 finger breadth, and the temporomandibular joint was insinuates 1 little finger. Thyromental distance was more than 3 finger breadth, and Malampati of grade 2. There were adequate neck movements and spine was normal. Coming to the cardiovascular system examination, on inspection, the shape of precordium was normal and apical impulse was not seen. There were no visible scars or sinus or pulsations. On palpation, inspectory findings were confirmed, and apex speed was felt at left intercostal, 5th intercostal space, medial to mid-clavicular line, and it was tapping of nature. There was left parasternal heave, and the diastolic thrill was felt in the mitral area. On percussion, the right heart border was retrosternal, and the left heart border we could palpate apex, and liver dullness in the right 6th intercostal space. On auscultation, S1 and S2 sounds were heard, and S1 sound was loud and in the mitral area. S2 sound was normal and loud in the pulmonary area. Opening snap was heard at the apex of the S2, and on auscultation, mid-diastolic murmur in the apex, which of low pitch quality and rumbling. It was heard with the use of bell of the stethoscope. Respiratory system examination. The shape of the chest appears normal and trachea was in the central midline. Bilateral chest expansion is normal and all lung areas are resonant and percussion. And bilateral normal vesicular breath sounds were heard. There were no added sounds. On central nervous examination, higher mental functions were intact, cranial nerve functions were intact. There was no motor or sensory deficits and no cerebellar signs were present and all reflexes are normal. On abdominal examination, abdominal appears scaphoid in shape. Umbilicus was central and inverted. All quadrants moved equally with respiration and tympanic node felt on percussion. There was no hepatosplenomegaly or no free fluid present. Suprapubic mass was present at corresponding to 12 weeks of size and hernial orifices were normal.
Summary of 45-year-old female patient presented with dyspnea on exertion and palpitations in 6 months. She has irregular menstrual cycles with excessive bleeding since the past 1 year, and a suprapubic mass was felt, which was 12 weeks size. There is history of recurrent fever with sore throat, hospital admission, and taking intramuscular injections during childhood. There is, on examination, elevated JVP, pedal edema, tapping apex beat with diastolic thrill was present. Loud S1 was heard along with mid-diastolic murmur, and opening snap was present.
The provisional diagnosis was stenotic pulmonary heart disease of mitral valve, probably rheumatic in origin, in sinus rhythm with features of pulmonary artery hypertension, without features of rheumatic fever, probably infective endocarditis, and not in heart failure, with a fibroid uterus posted for total abdominal history. Yes, sir.
Well, Shrabanti, na?
Yes, sir.
You said the patient had complaints of dyspnea and
Palpitations. Sir.
palpitations. How do you correlate this? How do you analyze?
Sir, dyspnea can be a symptom of respiratory or cardiac illness. In this patient, she has dyspnea on exertion, which has worsened over the past 1 year. Palpitations are usually a symptom of a cardiac lesion or anxiety. But since this patient doesn't have any specific aggravating or relieving factors, it's unlikely to be because of anxiety. It is probably due to a cardiac cause.
How do you correlate with your diagnosis? You said that it could be of heart mitral valve.
Yes, sir.
So how a mitral valve disease patient can have these symptoms?
Yes, sir. Sir, palpitations can be present if patient is experiencing atrial fibrillation. In mitral stenosis, because of the pressure overload, there will be dilatation of the left atrium. The dilatation will cause stretching of the conduction fibers, and it can result in atrial fibrillation. Dyspnea on exertion can be because of the pressure, the increased left atrial pressure, which is transmitted backwards towards the pulmonary vasculature and then to the pulmonary artery. This can result in pulmonary edema, which can cause dyspnea on exertion. And it is a fixed cardiac output state because of mitral stenosis, only a certain amount of volume of blood will go into the left ventricle and into the systemic circulation.
Yeah, you said initially patient had on exertion, then later on daily activity, household activity. So how this led to the increase in her rate of dyspnea?
Sir, if during exertion, even in normal individuals, there will be increase in heart rate and increase in stroke volume. In patient with mitral stenosis, when there is increase in heart rate, the time for diastolic filling will be further decreased. So this will result in increase in left atrial pressure. This pressure can be transmitted backwards and result in pulmonary edema.
Yeah.
What are the other precipitating factors for dyspnea in this patient?
Ma'am, this patient also has history of excessive bleeding since the past 1 year. So anemia can be a precipitating factor.
Okay. And what about palpitation? What could be, can palpitation, or in other words, anything lead to exacerbation of dyspnea in this patient?
Yes, ma'am. In this patient, atrial fibrillation itself can lead to exacerbation of dyspnea, because with atrial fibrillation, we will lose the compensatory mechanism of atrial kick, which will ensure normal cardiac output.
But at the same time, in your patient, I believe pulse is fine. You think your patient has atrial fibrillation?
Not at the
Could you-
time of examination, sir.
Yeah, then palpitation is due to what then? You're correlating palpitation to atrial fibrillation.
It can be paroxysmal in nature, so it won't be present during the entire time.
Yeah. Srinivas, you came out with the diagnosis of stenotic mitral valve.
Yes, sir.
How do you substantiate clinically?
So clinically on examination, on palpation, there was left apical impulse was tapping in nature, sir, and the left palpable thrill was felt, and it was rumbling in nature. Auscultation, it was a mid-diastolic murmur was heard on auscultation. These are the
Yeah. On history wise, can you grade the severity? No, on examination, sorry. On examination, can you grade the severity of mitral stenosis?
yes, examination. Sir, based on examination findings, if patient is having pulmonary artery hypertension, usually JVP will be raised and pedal edema. Patient presents with pedal edema. Usually, if class grade 3 and grade 4 patients will be having pulmonary artery hypertension and this raised JVP features and pulmonary edema features. Whereas in grade 1 and grade 2 patients, they'll be not having any raised pulmonary artery pressures in later stages. Usually in earlier stages, it is because of backflow of transmission of pressure from left atrium to pulmonary artery. Usually there will be initial pulmonary artery hypertension, but in later stages, it is because of intimal thickening of pulmonary artery, chronic pulmonary artery hypertension we can see, sir. And grading of mitral stenosis patients based on history. In grade 1 and grade 2 stages, usually apical impulse we cannot feel, all palpable thrill we cannot feel, sir. Whereas parasternal heave in grade 1 and grade 2 we cannot feel parasternal heave also, left parasternal heave. Whereas in grade 3 and grade 4 we can feel the parasternal heave, sir.
Any characteristic auscultatory signs which can tell you that?
Based on time between S2 and opening snap, based on that also we can grade, sir. Usually normal duration is 0.12 seconds. If it is less than 0.08 seconds, the grade is severe. In severe grade, it is less than 0.08 seconds. Whereas if it is more than 0.12 seconds, it's a mild grade, sir.
So you said that this patient is not in failure. What kind of failure do you see in mitral stenosis?
Usually mitral stenosis patients will land up with the right ventricular failure, right heart failure. Because of back pressure transmission of pressure from left atrium to pulmonary artery and pulmonary artery to right ventricle, they'll end up with right ventricular hypertrophy and a tricuspid regurgitation and say right ventricular failure usually.
So what kind of features will be there? What features do you expect in right heart failure?
Clinical features of right heart failure are raised JVP. On palpation of abdomen, we can feel the enlargement of liver hepatomegaly. Bilateral pedal edema, we can see, dilated chest, dilated veins or chest and dilated veins or abdomen, we can see on inspectory findings.
Anything else? Ascites?
Yeah, ascites, yes. Ascites.
Might have liver failure features. Jaundice could be there. Okay.
Yes.
Now you have come to the diagnosis, your provisional diagnosis. Now, how do you confirm? How do you confirm your, or what investigations you want to carry on?
For any surgical procedure, routine investigations that I would like to ask for are complete blood count, hemoglobin, platelet, and total counts. I would like to ask for the serum electrolytes and renal function tests. Along with that, I would like to ask for ECG and 2D echocardiography in this patient. And chest X-rays.
Why is the routine investigations, as you mentioned, important more so in this case?
Sir, in this patient, I need to know the baseline hemoglobin, sir. She has history of excessive bleeding. There can be anemia. Anemia should be corrected in patients with mitral stenosis because it can precipitate congestive cardiac failure. I should know total counts because I have to rule out infective endocarditis and platelet function tests.
Before I put this question, I wanted to ask you about the drug history. Did you ask any drug history here?
Yes, sir. Patient is currently not on any drugs, sir. She only gives history of taking medications in her childhood, after which she stopped on her own.
So right now she is not on any cardiac drug.
No, sir.
Except for that prophylaxis.
Yes, sir, which she took for 4 years and then discontinued.
Fine, go ahead.
So then ECG, I would like to see for changes of right ventricular hypertrophy, sir. There will be right axis deviation, right ventricular hypertrophy changes, and also dilated left atrium. There can be changes of P mitral, sir. Then P pulmonale can also be there, sir. Then 2D echocardiographic changes. The mitral valve thickening, calcification, the mobility of the mitral valves, then the mitral valve area and the flow gradient across the valve. I would also like to see for the presence of any clot in the left atrium, sir. And along with that, if there are any associated valve lesions like pulmonary or tricuspid regurgitation, and for signs of pulmonary artery and for pulmonary artery hypertension.
X-ray patterns.
Okay, we're sticking to echo. Are there any criteria to give the grading of mitral stenosis? Do you know of?
Yes, sir. There is a Wilkins scoring system is used, sir, to predict like prognosis after percutaneous balloon valvotomy. Otherwise, there is grading of MS based on the valve area and the gradient across the valves, pressure gradient across the valve. That is graded into mild, moderate, severe, with mild having mitral valve area of 1.5 to 2.5 centimeters. Moderate will be 1 to 1.5. Severe is less than 1. Pressure gradient will be less than 5 millimeters of mercury in mild, 5 to 10 in moderate, and more than 10 in severe.
There's one more variable in that, which was discussed in the lecture by Dr. Muralidhar.
Sir, pressure half time can also be across the valve can also be measured, sir. Based on that, if it's in mild, it will be more than 140 milliseconds, sir. Moderate will be 140 to 200 milliseconds, sir, and more than 200 milliseconds in severe.
Can you tell me what exactly is this pressure half time?
Sir?
Can you tell me what exactly is this pressure half time?
Sir, it's the amount of time taken for the pressure to decrease by 50% from the maximum pressure which is generated across the valve.
So, what happens if the pressure half time is more?
If the
Pressure of time is more time is taking for emptying of left atrium to the left ventricle, sir, and increasing the pressure in the left atrium. So chances of pulmonary edema are high if pressure of time is increased, and chances of pulmonary artery hypertension and right ventricular failure, going for right ventricular failure, are high with more pressure of time. Sir.
Correct. Yeah.
And even this S2 and opening snap, duration between S2 and opening snap, that also one of the parameters to grade the severity of mitral stenosis.
Many times we just grade, as it was mentioned in the previous lecture, upon the mitral valve orifice. Okay. So how do you grade depending on the mitral valve orifice?
So 1.5 mile normal valve area is 4 to 6 centimeters square. Mild will be 1.5 to 2.5 centimeters square. Moderate is 1 to 1.5, and severe is less than 1 centimeter square.
Critical is less than 0.8.
Something called as critical.
Less than 0.8
centimeters.
Yeah. When do you expect the patient to be symptomatic? At what valve orifice?
Sir, at 1.5 to 2.5 centimeters square, patient will only be symptomatic at the time of strenuous exercise when there are other factors. Whereas with less than 1.5 centimeters, patient can be symptomatic at rest also.
So maybe your patient had a normal valve area, and why did the patient develop symptoms?
Sir, our patient had a history of excessive menorrhagia since the past 1 year. So anemia and the associated like compensatory tachycardia could have been the cause for her developing symptoms.
So as you know, the pathophysiology is a fixed cardiac output. So any exertion will increase the heart rate. Yeah. So to maintain the transvalvular gradient, the LA pressure has to increase. So by this way, the patient might have had symptoms. What are other investigations?
It's a chest X-ray. I would like to get chest X-ray done, sir. In chest X-ray, we can see enlargement of left border of the heart, straightening of the left border of the heart. We can see the reverse mosaic sign or antler side.
Signs of edema can be seen.
So this patient, was any investigations done or?
Yes. We asked for investigations, sir. CBC, serum electrolytes, and serology, apart from random blood sugar, and chest X-ray and ECG and 2D echo was done, sir.
Rashmi, should we ask about the echo findings or?
Yes, sir. What was the echo finding in this patient? Echo finding in this patient? Echo was done, no, in this patient?
Rashmi,
Your patient.
sorry, Rashmi, I just a message. Manjunath Challakere, please mute yourself. You're disturbing. Dr. Manjunath Challakere, please mute yourself.
Ma'am, we don't have the investigations findings of this patient.
Okay. Okay.
So on the symptoms and signs, how do you grade this patient then?
Patient has symptoms and palpitations with less than ordinary activity, sir. And she also has signs of pedal edema, elevated JVP, which are so that suggests that she has mitral stenosis with pulmonary artery hypertension. So she would fall into grade 3, sir, moderate to severe or severe. Grade 3 or grade 4.
So how did you plan? What was your plan for anesthesia? How did you prepare the patient?
We planned for epidural combined spinal epidural anesthesia for this patient.
Okay.
Epidural for post-op analgesia and graded epidural, and low-dose spinal anesthesia for this patient. In the preoperative period, patient was advised to take anti-anxiety medications previous night, tablet alprazolam 0.5 mg in the night, and then on the day of surgery, tablet pantoprazole, protoporphyrin inhibitor form tablet pantoprazole 40 mg in the morning of surgery. Immediate.
So that was your plan. So
Yes.
you are thinking that it is moderate to severe mitral stenosis,
Yes, ma'am.
right?
Yes, ma'am.
What are your anesthetic goals in this patient?
Ma'am, the anesthetic goals were maintain the normal heart rate to avoid tachycardia or bradycardia, and maintain the systemic vascular resistance, and maintain the pulmonary vascular resistance, and maintain the normal contractility of the heart, and maintain the preload and afterload of the maintain the preload and afterload.
Okay. So if low dose spinal is your plan,
Yes.
what happens in spinal anesthesia? What happens to systemic vascular resistance? What happens to preload and afterload?
In spinal anesthesia, systemic vascular resistance will be decreased, and the preload will also decrease. Both afterload and preload both will decrease, and systemic vascular resistance will decrease in the spinal anesthesia.
So do you still want to go for spinal anesthesia?
So two of the goals of anesthetic considerations are knocked out.
We'd like to go for general anesthesia.
Yeah, with epidural.
With epidural for post-operative analgesia.
Okay. So as mentioned before, it all depends upon the severity or the NYHA grading. Okay. In NYHA grading 3 or 4, 3 and 4, and in moderate to severe mitral stenosis, it's better you avoid neuraxial block.
Only thing acceptable could be graded epidural if there is risk versus benefit. Graded epidural, that too. Okay. Do not tell spinal anesthesia. Okay, people, examiners may not agree with that, right? Yes. So, do you want to modify your plan of anesthesia now?
Yes, ma'am. For general anesthesia with combined epidural, we would counsel patient beforehand regarding the risk of the surgery and the procedure to be carried out. Pre-medication with tablet alprazolam and proton pump inhibitor night before surgery and in the morning. Then I will keep my OT ready with the appropriate size tubes, mask, laryngoscope, check the machine, keep emergency drugs ready. And I would also like to keep arterial invasive monitors like arterial line ready for the patient. And I will pre-oxygenate the patient for 5 minutes. I would like to pre-medicate with midazolam and pentanilma. And I would like to attenuate I would induce the patient with etomidate preferably, so as not to cause decrease in preload. And I would like to use muscle relaxants like vecuronium for paralysis. And I would like to attenuate the response to laryngoscopy and intubation with short-acting agents like esmolol or lignocaine. And my plan will be endotracheal general anesthesia with endotracheal intubation with controlled ventilation.
So after which one will you prefer, lignocaine or esmolol? You can choose one, whichever you use.
Esmolol, ma'am. Esmolol is 0.5 mg per kg.
Okay. Yes. Okay. Then after intubation?
Then after intubation, maintenance will be with isoflurane and with 1% and oxygen and air. I would like to avoid nitrous oxide in this patient because I'm suspecting pulmonary artery hypertension. And I would like to target tidal volume 6 to 8 ml per kg body weight. I would like to ensure normocapnia and avoid hypoxia.
And also other things what are the other things you would like to avoid and why?
To prevent increase in pulmonary artery pressures, I would like to avoid hypoxia, hypercapnia, acidosis, lighter planes of anesthesia. And I would also, to prevent increase in left atrial pressures, I would like to avoid tachycardia. I have to maintain normal sinus rhythm. I should avoid, because there will be loss of atrial kick if sinus rhythm is lost. And maintain preload and afterload.
So
how do you monitor the intravascular volume? How do you maintain? You said maintain preload, na? So any guide for maintaining the preload?
Yes, here we are monitoring the systolic SVP. Here we are monitoring the SVP, sir, in our hospital setup. SPV, systolic pulse variation, sir.
Okay.
So otherwise, we can use central venous pressure monitoring, CVP monitoring.
if we assume that everything is available, which one would you prefer? What do you want to do in this patient?
Nowadays, CVP monitoring they are not using CVP monitoring. Systolic pulse variation, SPV or PPV, they are using.
Pulse pressure variation is.
Yes,
Yes. So you want to also secure an arterial line. So
yes,
you want to secure an arterial line before or after induction?
Before induction.
Okay. Then what about ETCO2? You want to monitor that?
Yes, ma'am. Entitled carbon dioxide, it is okay.
Okay.
As madam mentioned before, if all the facilities are there, anything else you want to go ahead for monitoring, intra monitoring?
Echocardiography can be used, sir. That will detect any acute changes in the left atrial pressure along with left ventricular ejection fraction.
So it can also tell you the volume status.
Yes, sir.
As well as ventricular functions, biventricular function also. Okay. What about PAC?
Sir, pulmonary artery catheters are not routinely advised for patients with mitral stenosis with pulmonary artery hypertension because the chance of rupture of the pulmonary artery is increased in these patients.
And also benefit is less.
Less.
Yeah. Okay.
So what are the different intraoperative hemodynamic alterations you see, you anticipate, and how do you prepare, how to prepare yourself?
At the time of induction, sir, if we use If we use any agent which will cause decrease in systemic vascular, there can be hypotension at the time of induction, sir, followed by tachycardia and hypertension at the time of laryngoscopy and intubation. Then if there is intraoperative blood loss, that can result in decrease in the preload.
Can you mention the treatment as and when you tell about the alterations, what you're saying? How do you treat?
Sir, for induction, we should use drugs which do not cause hemodynamic instability. We can use graded doses of etomidate. For prevention of the sympathetic response for laryngoscopy and intubation, we can use short-acting beta blocker like esmolol. And by continuously monitoring the intraarterial blood pressure and the venous return, we can, in case of excessive blood loss, we can start blood transfusion early. And at the time of extubation, again, we have to blunt the response and prevent the patient from bucking on the tube. Again, we can use short-acting beta blockers, and we should provide adequate analgesia throughout the course of the surgery.
Now, suppose intraop there is hypotension, how do you treat?
Intraoperative hypotension should be treated with injection phenylephrine rather than going for ephedrine or mefentermine. Should be treated with phenylephrine. Dosage of phenylephrine, usually it is 30 to 50 micrograms IV bolus. Can be given up to 100 microgram IV bolus.
At the same time, we should know about the volume status also.
Yes.
What other problems can you anticipate intraoperatively?
We can anticipate a patient going for atrial fibrillation, especially in patients with mitral stenosis, because of increased in patients with increased left atrial dimensions, stasis of blood, and patients going for atrial fibrillation. So once patient goes for atrial fibrillation in perioperative period or intraoperative period, it should be treated with if it is if patient is not on any anticoagulants, then within 48 hours we can cardiovert the patient in perioperative period. Otherwise, if patient's hemodynamics are normal, there are no hypotension or perioperative period, it can be treated pharmacologically also in perioperative atrial fibrillation.
Can you be more clear?
Regarding management of perioperative atrial fibrillation. Yes, perioperative atrial fibrillation without any hemodynamic instability can be treated pharmacologically. The pharmacological agents of atrial fibrillation are injection amiodarone 150 mg IV bolus followed by infusion of amiodarone 1 mg per kg, 1 mg per hour for 6 hours and 0.5 mg per hour for next 18 hours. Other pharmacological agents of AFR, it can be treated with injection digoxin also. Digoxin 1 mg IV bolus followed by 0.25 mg every 4 to 6 hours, or we can give.
Okay, diltiazem. Okay.
Yes, ma'am, diltiazem.
Yes.
10 mg.
Okay, if it is unstable, what do you do?
If it is unstable, if patient has not taken any anticoagulants, then we can cardiovert the patient with 100 to 120 joules of biphasic shock synchronized cardioversion.
Synchronized cardioversion has to be done.
Yes.
Unless if at all it happens in the post-op and you have an what are the things you're thinking before doing cardioversion? What should you keep in mind? What you're concerned about?
In the post-op period, as patient is extubated and she is conscious, we have to sedate. We have to sedate the patient before doing cardioversion.
Okay.
And
what should you be careful about?
We should
before
rule out
cardioversion?
the presence of clot
in the left atrium. Yes. We should do 2D echo before doing cardioversion in AF cases.
Yes. Okay. Then any other complications you can anticipate in the perioperative period?
There can be acute pulmonary edema because of increase in pulmonary artery hypertension. And if patient is intubated, then we should give 100% oxygen and take up patient for elective ventilation. If this happens in the post-op period, then we should give patient oxygen via 100% oxygen via face mask, diuretics, loop diuretics, 1 mg per kg, and we should try to correct the cause of like whichever precipitating factor is affecting pulmonary artery hypertension.
Positive pressure ventilation can also help.
Yes.
Okay.
Post-operatively, how do you want to manage this patient?
For post-operative period, as we have secured epidural catheter in the, you can give epidural opiates. You can give opiates in epidural analgesia. Opiates in the form of injection morphine 1 mg to 2 mg, dilute to 5 to 6 cc, epidural thrice a day. Otherwise, we can add a 0.1% or 0.625% of bupivacaine along with opiates as a form of epidural analgesia. If epidural catheter is not secured, we can give analgesics in the form of NSAIDs or IV opiates in the form of injection fentanyl.
What is the importance of post-op analgesia in a patient with mitral stenosis?
Post-op if patient does not have adequate analgesia, they will have sympathetic stimulation and there will be increase in tachycardia, which will cause increase in left atrial pressures, increasing the back pressure on the pulmonary artery and the pulmonary vasculature. This can cause pulmonary edema, or it can also precipitate right ventricular hypertrophy and right ventricular failure. Sorry, and this increase in this tachycardia will also decrease the diastolic filling time and further reduce the cardiac output.
So you want to summarize your diagnosis and your management in short?
Yes, sir. 45-year-old female with stenotic valvular heart disease of mitral valve, rheumatic in origin with features of pulmonary artery hypertension, without rheumatic fever, infective endocarditis, not in heart failure, with fibroid uterus, who's posted for total abdominal hysterectomy, to be done under general anesthesia with endotracheal intubation and controlled mechanical ventilation, along with epidural for postoperative analgesia.
Your intraoperative goals will be?
My intraoperative goals will be to maintain sinus rhythm, to prevent tachycardia and bradycardia, to maintain the preload and afterload, and to
vascular resistance and
maintain contractility.
And maintain the contractility.
One thing what we missed discussing is bradycardia. Why bradycardia also is equally important? To avoid bradycardia.
So usually, if patients who are on digoxin therapy, so the anesthetic implications, the patients with
why bradycardia should be avoided? That is the main thing.
Sir, if there is bradycardia, already these patients are having low cardiac output, sir. Usually,
fixed cardiac output.
Fixed cardiac output, sir. If there is any bradycardia, the contractility of heart cannot compensate the ejection of the stroke volume. It cannot compensate the stroke volume, sir.
Okay, the cardiac output cannot be maintained.
Yes,
the stroke volume is fixed. So if we cause further reduction, the output will be further down. Okay.
Sir, why to avoid bradycardia is the transvalvular gradient depends on the cardiac output. So it's square of cardiac output. So if there is any bradycardia and they fall in cardiac output, definitely the trans gradient pressure will also fall. And patient will end up in left ventricular failure rather than right ventricular this thing. We can anticipate left ventricular failure if there is any bradycardia. And even in patients with right ventricular hypertrophy and right ventricular failure, if there is any bradycardia and a decreased cardiac output, it will cause right ventricular failure. It will cause right ventricular ischemia and it will cause right ventricular ischemia also. Sir. Because right ventricle, it depends on both systolic and diastolic. Perfusion pressure of right ventricle depends both on systolic and diastolic.
The last point about left ventricle.
Yes.
What happens in mitral stenosis and any other changes in left ventricle, and due to what?
Sir, in mitral stenosis, because there is a fixed inflow into the left ventricle, there will be decreased left ventricular end diastolic pressure, and over time this will result in left ventricular disuse atrophy, sir. So there, although it's not as common, there can be left ventricular dysfunction in patients with mitral stenosis.
Otherwise, most of the times it is?
Most of the time it will be right ventricular failure first, sir, but left ventricular dysfunction can also be present.
So to summarize, what I feel is in NYHA grade 1 and 2, you can go ahead with not only spinal, it's more of graded epidural what we advocate, not spinal at all. Okay. And in NYHA grade 3 and 4, it is well managed general anesthesia with very good postoperative analgesic technique. That is what we advise. It can be epidural or it can be any blocks also if the patient is not. We also to take care about the anticoagulants if the patient is on anticoagulants. Okay. We have to follow the guidelines of regional anesthesia with anticoagulants also if they are on anticoagulants.
Yes.
Rashmi, anything else?
No, sir, I think we can find.
Thank you. Thank you, Dr. Mani and Dr. Rashmi. Excellent presentation by the postgraduate Shravanti and Srinivas. Don't you agree, Dr. Rajesh?
Yeah, absolutely.
They're cool and they did answer a lot of questions. And now let's keep this open for any questions from the audience. You can either directly unmute yourself and ask the questions or type it in the chat box. We'll take up the questions from there. Shravanti doesn't have to get so worried. The questions could go to the consultants themselves, both the cardiac anesthesiologists.
Yeah.
Okay, we have a question from MRK. I'm not very sure of the name. What is left ventricular ischemia? Rajesh, any light? Shravanti,
yeah,
there's a question. What is left ventricular ischemia? Left ventricular ischemia.
As I think Shravanti or Srinivas, somebody had a comment on that also. So many times it so happens that because of decreased left ventricular filling, there's some of atrophy, and there can be coexisting CAD also in these patients.
Yeah.
And there will be some scarring, left ventricular scarring because of this papillary muscle dysfunction. So this could have lead to left ventricular ischemia in the long run.
I hope that answers your question, Dr. MRK. Any other questions? Thank you, Dr. Rajesh Mane and Dr. Rashmi for this excellent moderation, and Shravanti and Srinivas.
Thank you.
Good job.
Thank you.
Thank you, organizers.
Thank you for participating in our program. And now shall we move on to the next program, Equipment of the Month, the LMA Family by Dr. Manjula Devi, Professor of Anaesthesiology, St. John's Medical College, Bengaluru. Over to you, Manjula. Dr. Manjula?
Yes, so I'm just trying to share the screen. If you would allow me for that.
It's not allowing you to share the screen? Manjula, are you able to or not able to share the screen?
Not able to, Suma. Somebody has to allow me, I think.
Manjula, I'm making you co-host so that you can share your screen.
Yeah, great.
Okay, are you able to see my screen?
Yes, we can see it, Manjula, but not your PPT.
PPT?
Is it a PPT?
Yeah,
Institutional Ethics Committee. That's what I can see. General post.
Yeah.
Well, now,
slides, Manjula.
You have to take a screenshot.
I'm sharing the PPT, Suma.
Okay.
It's not come.
No, I can see something else. It's not. Have you opened your presentation on your desktop?
Yes, just now I hope.
No, you don't.
Now?
December IEC meet. Now it's come. I think somebody else was.
You do it.
Yeah. We can see you now, Manjula.
Okay. You can see my screen, right?
Yes, I can see it.
Okay, thank you. All right. At the outset, I would like to thank Dr. Suma and Dr. Sripada and the whole Kshema unit for conducting this Nitte education series. It really gives me an exam fever, especially when I hear the case of mitral stenosis coming for an incidental surgery and the questions that the examiners were moderating in these sessions. I take this opportunity to also wish every exam goer here who is witnessing this good luck for their exams. Greetings from my hospital, St. John's Medical College Hospital, and I'm going to do a brief presentation on the LMA family. Okay, now, most of the times when we look into why we need an airway device, it is for oxygenation, ventilation, or administration of anesthetic gases. And if you look into the level of airway instrumentation, and in relation to the anatomic position, the tracheal tube is more an invasive and infraglottic placement of the tube. Whereas the extraglottic, you have the laryngopharyngeal airways, supraglottic airways, the esophageal blockers. And face mask also we do use sometimes to conduct anesthesia. Looking at the evolution of the LMAs, initially in the 1980s, it was just between, we had only two choices, that is the face mask and the endotracheal tubes. As we moved on to 1990s, we had a choice of having the classical LMA because it was invented by Archie Brain in 1981. And then we had choice between face mask, classical LMA, and endotracheal tube. Over a period of evolution of the LMAs that happened, we started having first generation, second generation, supraglottic airway devices that came up into the market. And then we had a choice between this along with the endotracheal tube whenever we had to give anesthesia. And what are the advantages of the LMA over the mask? One, it is very reliable and secure. Of course, everybody wants to give hands-free anesthesia. There's no need to support mandible and manipulate, especially in terms of depth of anesthesia. Minimal training is required, whether it's medical or the paramedical, the anesthetic nurse or the anesthesia technician who is around with you. When it comes to LMA advantage over the endotracheal tube, all of us agree that it causes less stress response, whether it's an intubation or an extubation, or in particular eye surgeries or the head and neck surgeries, definitely, and decrease in the IOP or the ICP. Less anesthesia is required. Not all the time you're using the neuromuscular blockers. Less post-op morbidities such as laryngospasm, bronchospasm, post-op sore throat. And LMA over the endotracheal tube definitely is an advantage for both medical and the paramedical person. Just a little note on the history. All of us cannot forget Mr. Archie Brain, because of whom this whole invention of the LMA happened. And if you look, he was actually administrating as a dental anesthetist when he came up with this idea of using this Goldman dental mask, which is a nasal mask. He found a lot of similarity between the seal of the dental nose mask to that of the space around the larynx in his cadaveric cast. So what he decided to do is he cut the endotracheal tube, utilized the dental nose mask, used the little support, glued them together, and kind of made one tube so that it gives an airway passage. So that's Archie Brain in 1981, when he didn't even know what is happening, and he wanted to do something that can be somewhere between endotracheal tube and face mask. And he was not sure whether he's going to really come into such a big evolutionary change that happened thereafter. So these are some of the prototypes that you see and evolution that has happened. The first one being from the Goldman cuff, then latex cuff, then the Dunlop cuff and classic cuff. And thus Archie Brain now, we had the opportunity to listen to him last year, where he was, even now he wants to get involved with a lot of new things that is coming up across LMA. And even now he's involved with Dr. Anil Patel in UK to do many things in terms of airway. There are no universal classification per se, and we need to have some international guidelines based on functional and safety of the LMAs. But there are two classifications already mentioned, which I still want to quote here. One is based on the sealing mechanism by Miller. He classified them as cuffed and cuffless. Amongst the cuffed, he called them as perilaryngeal sealers and pharyngeal sealers. In the perilaryngeal sealers, there were non-directional sealing such as LMA, directional sealing like LMA Supreme and Procil LMA. Amongst the cuff pharyngeal sealers, there were without esophageal sealing such as COPA, with esophageal sealing such as Combitube. Amongst the cuffless, we are familiar with this Basca and the Slipper and the Ideal that we are having now. Cook came up with the classification based on generation. He said the first generation contained just a simple breathing tube, usually some form of mask or opening at the larynx, which we see in classical LMA. The second generation came up with some improvement over the first one, which involved having a gastric drainage and also some protection against aspiration so that we could ventilate with the higher pressures and be using it for positive pressure ventilation. Above this came up the third generation, which was a proposed idea, which incorporated the dynamic sealing mechanism that is involved in Basca mask. What are the indications of LMA? So basically it's a primary airway management device. It can be used in operating room, non-operating room procedures, emergency room, pre-hospital care as well. It is also an airway rescue device. It's a conduit for endotracheal intubation. It is used in extubation. It is also used in percutaneous dilatation tracheostomy NAES setup. The contraindications are anything which involves aspiration risk, be it morbid, obese, OSA patients, or any full stomach cases as well. Any expected difficulty with insertion or ventilation, such as reduced mouth opening, pathology of the glottic area, supraglottic area, extraglottic area, subglottic region, any chest wall deformities, severe COPD, any fixed C-spine flexion deformities, all these are a contraindication. When there is a patient positioning surgery involving prone, lithotomy, or Trendelenburg, very cautious to be used. And of course, whenever there's a limited airway access during ventilation, better to go with the endotracheal tube rather than an LMA. A slow description on the equipments on the LMA family. So all of us are familiar with this LMA Classic. It's got a cuff, silicone-based, and a tube. It has got a 15 mm connector, which is attached, and it has got a pilot balloon through which through this self-sealing valve, through which we inflate, and the cuff gets inflated, and that's how it sits in the perilaryngeal area. Similar to that is the Flexi LMA. The only difference is that it is a little smaller, and it is reinforced with multiple coils-like structures inside the lumen of the airway tube, and is used more so in the head and neck surgeries. The LMA Fast Track is an intubating LMA, so it has got its own endotracheal tube. It has got a preformed curve, and it's got a handle. So the endotracheal tube of the LMA fast track can be utilized through this. And there is an elevating bar, as you see over here, epiglottic elevating bar. And this is used for LMA placement. And then connect to this connector over here and connect the circuit and use it for the cases. The difference between LMA C-track and LMA fast track is that the advantage of utilizing the viewing screen to see where the tube is going. So that's one advantage of having the C-track around. If you look into ProSeal LMA, in 1990s, I said already that the difference was only between classical LMA and tracheal tube. But as we moved further in 2004, ProSeal LMA came with the added advantage of being a second generation. So what we see over here in the lateral side of the airway tube is also a gastric channel. And this is what is called as the rear boot or the dorsal cuff. So it's an extra cuff that is being used over here. And over here, the airway tube is also reinforced with wires. And this particular seal has got this drainage port, or the drainage tube that you see here has got a port at the esophageal end. So if you see over in this picture, as you inflate the cuff, the dorsal cuff also kinds of pushes against the posterior pharyngeal wall and elevates this cuff so that it gives a better seal over the perilaryngeal structures. So advantage of this is a particular LMA is that you can use this for positive pressure ventilation. And also you can higher generation of pressure can be utilized. Like for example, the classical LMA is somewhere between say 15 to 25. This can go up till 35 centimeters of water. Then came the LMA Supreme. So if you see over here, it's already got a preformed angle. And there are two tubes. One is the airway tube and the gastric channel behind. It is elliptoid in structure. The advantage of this is it has got two separate seals, as you see over here. So this is the oropharyngeal seal. And this over here in the tip is the hypopharyngeal seal that is happened. And over here in this sideways of the seal, you can see what is called as the epiglottic fins. So advantage of having an epiglottic bar, epiglottic fins, or aperture bars that you see in classical LMA is to avoid any epiglottic obstruction that causes or obstructs the airway passage. So this is the way you insert the Supreme LMA. You can also utilize the aid, which I'm going to talk about it a little later. So now some of the new devices that are in market is the LMA protector. So the advantage of this is it's got dual gastric access. One is called as a male suction port and a female drainage port. So here you see the airway tubes, and this is the drainage ports that has, and this is the seal, double seal technology. The first seal facilitates for the oropharyngeal and the second seal facilitates for the esophageal. The advantage of this is that it has got what is called as a cuff pilot valve, which is also MRI safe. And this is a self-integrated cuff monitoring. Integrated cuff monitoring is there. So there is, as you see in this particular picture, there's a black line over here. When you inflate the cuff, if the black line is in the green zone, that means it's an optimal pressure. So 40 to 60 centimeters of water is what is optimal pressure. So if the black line falls onto the yellow line, as you see in this particular thing, that means that the pressure is less than 40 centimeter of water. So it means that there might be still under inflation of the tube. So you have to inflate it a little more. If the black line moves towards a red zone, that means there's an overinflation, that is more than 70 centimeters of water, which is very critical. So you need to probably deflate the cuff. So that's the advantage of having a LMA protector with an inbuilt cuff pilot valve. Then a newer device has come up in market, which is called as LMA gastro airway. This is utilized in interventional endoscopic procedures these days. So you have this particular endoscope, that is the gastroendoscope, that is going through the gastric channel, a separate one, as you see here over here. So you have the gastroduodenoscope pierced through the pharyngeal wall, and then also you can have big particular like endoscopic ultrasound probe that can be also used through this end. And nowadays the cardiac anesthetists are looking whether transcerebral echo also can be given through this particular LMA gastro and utilized for some of the intervention procedures that can happen in cath lab. Coming to the various techniques of insertion of the LMA, one is digital, second is introducer. You can utilize certain aids like bougies, stellate, airway exchange catheter. You can also use laryngoscope, or the fiber optic would be the most surest one. So this is how we all have been taught about how to use a classical LMA. First of all, you deflate the cuff completely, and so that this is completely deflated. Then inflate a little so that there's a little flap of the seal before you insert. hold the LMA, insinuate your finger between the shaft and the cuff over here, and pass it along the posterior pharyngeal wall, hard palate, soft palate, taking a curve until you see the resistance. Once you see the resistance, which is at the hypopharyngeal area, alternate your hand and try to insert a little more and inflate the cuff. And once it is inflated and the cuff is in situ, you can immediately connect to the circuit and check for the chest expansion. Now in the thing about the Procil LMA, you have introducer over here. So you have this metallic introducer. So you can see in the anterior bit, the tip of the blade is inserted over here. And in the distal part of the introducer, you have both the gastric channel and the airway tube sitting on the sideways. So it gives a triangulation with the help of the introducer. And then that gives a very easy insertion into the airway passage. So also alternatively, you can use what is called as an airway exchange catheter or a gum elastic bougie or a stilette that can be passed into the gastric channel. Use a laryngoscope and see that this goes into the gastric port, in the gastric passage, and then place the LMA and inflate the cuff. So this is the way we insert the LMA Supreme, almost the same, but here you see it is such an easy mechanism because it's already a preformed shape. You just have to hold your fingers and go in the similar way along the posterior pharyngeal wall, hard palate, soft palate, taking a circular motion, and then going until the resistance is felt, and then inflate the cuff and connect to the circuit. Chandis maneuver is utilized for intubating LMA. There are two particular steps. One is for optimal ventilation. So the intubating LMA is moved either sagittal or in a coronal plane with the help of that metal handle that you see until no resistance is seen in the ventilation. And this is also, intubating LMA was also known for using blind intubation, where you are not using a fiber optic scope, but you are using the endotracheal tube associated with the intubating LMA, which comes with it, and passing through the introducer until the endotracheal tube slips inside to the airway passage. So little maneuver is required. That is, you move the metal handle, lift it up a little so that it kinds of moves away from the posterior pharyngeal wall and helps in movement of the endotracheal tube into the anterior passage here. Fiber optic is definitely the surest sign through which you know that the LMA is sitting properly. So Brimmer-Combe scoring is one of it that you utilize in the fiber optic, where you see either only the vocal cords or you may not see any vocal cords, which means that this is totally a failure. That means that you have to kind of remove the LMA and reinsert it again. So there are manufacturer details that have been mentioned, which is based on the size of the LMA, based on the weight and amount of volume of air that has to be injected. Important over here is to keep the LMA pressure, cuff pressure under 60 centimeters of water. So this is something called as a cuff pressure monitor. So as soon as you inflate the cuff, measure the cuff pressure and see to that it is less than 60 centimeters of water. So what are the intraoperative parameters that we need to look? Obviously, the subjective findings are looking into the chest raise or an auscultation. The objective finding being the ventilatory parameters or the airway dynamics, such as the end-tidal carbon dioxide, the peak airway pressure, the exhaled tidal volume that you want to look. And hemodynamics, both during intubation, extubation, all this does alter. So it's important to have the hemodynamics also to be looked on. Cuff pressure, I've already talked about this. So minimum volume of air that has to be injected that produces the best seal and provides adequate ventilation is what is really required. So routinely monitor the cuff pressure, especially when you're using nitrous oxide prolonged surgeries, the cuff pressure may start increasing. So if the clinical endpoints do not correctly estimate the cuff pressure, and higher pressures does not mean that there's a good seal or a lower leak. So this is something, then inline cuff pressure monitoring, which is used with the pressure transducer. You can monitor, see over here, you can see that with nitrous oxide usage, it has gone a little high. And this is the regular cuff pressure that is portable that can be used as well. The anatomical structures related to the LMA placement, if you see over here, this is exactly how it is. So the LMA, the look and the structure of the LMA is so designed that it is placed in close proximity to the larynx. The tip lies in the upper esophageal sphincter. The lateral walls over here, they approximate to the aryepiglottic fold, and the base of the LMA cuff across the base of the tongue. There are two important sealing that is very necessary to be mentioned. One is called as gas seal and one is called as fluid seal. As you see over here, this is the gas seal. That is, it's the seal with the around the periepiglottic area. So once we inflate the cuff, the seal that across the periepiglottic area is called as gas seal, whereas that which protects regurgitation fluids away from the airway passage, that is any fluid coming from the upper esophageal sphincter, is protected by the little distal cuff, that is the fluid seal. So the gas seal is expressed in terms of air leak pressure, which is very important when to know about the good placement of the LMA. So this is a BJ article which has shown the actual ideal position of how the LMA should be sitting. In this is a mannequin and this is in situ. And if you see that sometimes when it is too deep or it is very, kind of underinflated, and sometimes it is, the tip is lying on the cords, or you can see that the epiglottis is getting folded. All this suggests that there is no good ventilation. That means that the LMA is in a malposition and we need to reinsert it again. So the one of two big threats is we'll have inadequate ventilation, and there are always a chances of aspiration when the LMA is in a malposition. So beware of the reused cuffs, especially. This is the ProSeal. This is one of the ProSeal LMA where the cuff has got herniated. See, look at this. This has got herniated. So that will not give a good airway passage, and that's why you will see inadequate ventilation when such a thing has happened. So there are certain placement tests and performance tests that are demonstrated when you put in, especially the second generation supraglottic airway devices. So one is called as a SOAP or a bubble test, and one is suprasternal notch tap test. So this shows how deep the SAD is sitting in the post-cricoid region. So if you put a little bit of a drop of gel on the drainage tube, and if there's no bubbles detected, that means that it is in correct placement. Or when you see that, when you see that gel moves synchronously with the suprasternal pressure, that also means that it is in correct placement. If you are able to insert a gastric tube in the gastric drain, and if without resistance, the gastric tube goes in, that means the LMA is sitting in correct position. There's something called as performance test, which is also important. One of it is the oropharyngeal leak pressure. So this tells us what's the maximum peak pressure to ventilate without a leak. So what we do is we set an APL valve to less than 30 centimeters of water, put in fresh gas flows to less than 3 liters per minute, and note any pressure at which the audible leak occurs. If the pressure after a little time goes on a plateau phase, if it is more than 25 centimeter water or more than another 8 centimeter above the peak airway pressure, which was measured under pressure control ventilation with normal ventilation and in supine position, as happens in laparoscopy, that means the LMA is sitting in a correct position. There's something also called as maximum minute ventilation test. Here we are going to see, this is basically assessing the ventilatory function of the supraglottic airway devices. Perform 4 maximum breaths in 15 seconds and calculate the minute ventilation. If it is more than 12 liters, that means it is in a good position. So what are the complications that arises with an LMA? Even in spite of so many new evolutionary changes of the LMA, the complication is still happening. And some of the main complications are definitely the ventilatory failure, the airway injury, and pulmonary aspiration of the gastric contents. So over here, it could be either because of a direct injury when you are placing the LMA, or it is an indirect injury. When I say indirect, it is an overinflation of the cuff that has caused compression. And like as you see over here, there could be as severe as arytenoid dislocation or some nerve pulses, even fracture of teeth roots have been mentioned. And the prolonged compression can be because of prolonged surgery or because of too high pressures as well. So if you see this nerves, there's in so much of close proximity to the perilaryngeal structures that any overinflation of a cuff or in a prolonged surgery can compress on this particular nerves as well and cause nerve injury. So these are some of the cranial nerve injuries that were reported, some all on lingual nerve, recurrent laryngeal nerve, hypoglossal nerve, glossopharyngeal nerve, inferior alveolar nerve, infraorbital nerve. All of this were reported in the 355 articles that were in the search. So to prevent such complications of nerve injury, always select appropriate size LMA, use standard insertion technique, and ensure the intercuff pressure is less than 60 centimeters of water. So it's okay to err on a bigger size LMA and use lesser cuff volume rather than using a smaller LMA and kind of overinflating with higher volume. Vascular compression is also noted. So one of it is this tongue cyanosis that is caused by the compression of the blood vessels of the tongue. There's also noted decreased carotid blood flow that has happened with the overinflation of the LMA. So do beware of this vascular compromises that can happen. So the crux of the ventilation is actually an effective seal of glottis. So oropharyngeal seal pressure, which I've already talked about. If it is a good seal, that means we facilitate good ventilation. And lesser leak into the esophagus that can prevent any rise in the intragastric pressure, which will reduce the regurgitation. And clear view of glottis using fiber optic definitely confirms about that. Now, this is one article where they did an analysis of the LMA with tracheal tube. 65,712 procedures were looked with positive pressure ventilation. And what they found amongst the 35,630 LMAs and 30,082 tracheal tube procedures, they found that there were the incidence of the pulmonary aspiration was lesser with LMA and higher with endotracheal tube. So one would wonder the other way, isn't it? We'll think that the endotracheal tube is supposed to give us more safety rather than LMAs, but here it looks a little paradox. So whenever you read such an article, beware that this is one of those particular example, which is a retrospective analysis. There could be selection bias, there's a detection bias, there could be a reporting bias. So do not go with just 1 or 2 episodes of this and say that LMA is definitely going to be more useful and can prevent pulmonary aspiration. So some of the post-op morbidity normally seen is cough, hiccups on removal, laryngospasm, hoarseness, post-operative sore throat, not very good in ambulatory surgery, dysphonia, and dysphagia. So here it is in one of the laparoscopic surgery. Again, it was noted that all of this kind of post-op morbidities was higher in the endotracheal tube. And they did confirm that using the supraglottic airway devices may be useful and may prevent such a kind of episodes to happen. So in this particular era where we are looking at single use versus reusable devices, cost factor is one of the big things. It's not only about the cost factor of the single device, but also about the overall cost that is involved in infrastructure, time and staff that is required to re-sterilize the reusable devices. And also we have to think about the contaminants like prions that happens when you're using the reusable. So all reusable elements should not be used more than 40 times as mentioned in the textbook. Moving towards the advanced use of SAD. So we have LMS that can be utilized for as an airway rescue, a conduit for an intubation, and also for extubation procedures. So AIDA very clearly has given in step 2 that if we have a failed intubation, resume mask ventilation with 100% oxygen, and preferably use a second generation supraglottic airway devices, insert them to maintain the oxygenation. In case you succeed, continue the anesthesia with this. If you want to intubate, definitely use a fiber optic scope and do not do any intubation blindly through the SAD. So these are some of the mentioned supraglottic airway devices amongst the LMA family, the ProSeal, Classic, Supreme, all of these have been used for the conduit for the endotracheal intubation. Important is to always look into the fiber optic scope that they're all seated very nicely before you confirm anything more. So this, I'm not sure if this video is, I don't think this video is going to work, but yes, intubation can happen through the LMA. If you see in the classical LMA, there are aperture bars that prevents in the tube passage, whereas nowadays you get what is called as a FlexiCare Larisil LMAs, where you do not have such kind of aperture bars. So you can use the fiber optic scope directly through it and facilitate the endotracheal intubation as well. So when you're using the LMAs, beware of what kind of tubes that you're using. So as you see in this particular picture, this is the LMA protector that has been used. So you have the same size of the tube, but different designs of the tube. And if you look over here, the length of the tube is quite different. And if you also see that the cuff distance from the tip of the tube also is different. So beware of these particular things as an alert sign. And this particular picture on the right-hand side is showing about usage of the LMA Supreme for intubation as a conduit. And over here, if you see that the fiber optic scope along with the endotracheal tube is directly passed through this. So probably what you would have used here is a 6 mm endotracheal tube. And many times you can also use an FOVA introduced over here and have the fiber optic scope on the other side. So in LMA Supreme, we should be aware that there is what is called as the epiglottic fins that are there. And also you can also utilize airway exchange catheters or entry with the fiber scope. So use the fiber scope with the entry. And once you know the LMA is sitting in place, then remove the fiber scope, keep the entry there, and through this entry, pass the endotracheal tube. Once you know the endotracheal tube is in and confirm it, remove the LMA. So that is how we use the LMAs for as a conduit for endotracheal intubation. IDA also mentions the anticipated difficult extubation, the role of the LMAs over here. So they do mention that whenever you are planning for a deep extubation, utilize the supraglottic airway devices, remove the SAD when the patient is fully awake. So alternative to having the endotracheal tube and having an extubation response for it. So Bailey maneuver is such a maneuver where there is exchange of an endotracheal tube for an LMA. So advantage of this is that there is decreased sensitivity or severity to cough, any hemodynamic changes, or even post-op sore throat. So how do we do it is you can have the LMA placed behind the endotracheal tube and then deflate the cuff of the endotracheal tube and get the endotracheal tube out. Basically, you're replacing the LMA to the ETT. And then once the LMA is in, inflate the cuff, reconfirm it is in, and ventilate this patient. Then you give the reversal agent. And once the patient is fully awake, extubate this patient. So this is the video that is showing about the extubation. So we have the surgery finished on this particular patient. So placement of the LMA behind the endotracheal tube. So deflating the endotracheal tube, removing the endotracheal tube. So connecting the LMA, inflating the cuff of it. And confirming the position of this. So if you see over here, you can see a good ET graph that shows that LMA is in place. Okay, these are some of the case reports that have come up with IJA where they've utilized this LMA both in the, basically a case report of thyroid surgeries. If you see over here, so they've put the LMA protector and through this, the fiber optic scope. And they've looked into the laryngeal views and seen how the larynx is actually looking. And post extubation, they've also have, that is, kind of looked into the laryngeal view and basically to look into the vocal cord mobility. So it is used both for, pre-intubation and post extubation. It can be utilized to know about the vocal cord issues. So this is one particular case again where they've used the LMA classic. This was an extubation of a difficult airway after a thyroidectomy. So if you see in this particular picture on the left-hand side, the bronchoscope intubation did show some tracheal abnormality. So basically this patient had a little bit of infraglottic mass and that some resection and tracheal anastomosis was also done. And just before extubation, they put in the fiber scope and just saw about how good the tracheal anastomosis is. Once they knew everything was fine, and looked at the vocal cord movement, they were able to extubate this particular case on the table itself. So advantage of having the LMA as even for extubation is good. So other advanced application of LMAs is when you want to use for a prolonged surgery. These days, having second generation is a blessing. So they have been using LMA for prolonged surgeries such as neurosurgery as well these days. 2 to 8 hours is the longest that has been kind of accepted. In ICU, when there's one of the rare circumstances, they've gone up to 24 hours. What is more important is to alert ourselves that there can be an increased risk of aspiration or a pharyngeal morbidity. So we have to be very vigilant and provide adequate anesthesia and throughout monitor the intracuff pressure. So this particular picture showing LMA used on a prone position. So these are some of the advanced application of the LMAs. Now, what about the evidence over here? So this is one of the articles that came up in 2014. Which was from one of the hospitals' usage of endotracheal tubes and LMA. As you see here, once the LMAs have, the generation of LMAs have increased, the usage of LMAs did go high and the usage of endotracheal tube did come down. And once we had a second generation, the utilization of second generation also went higher. And if you see most of the kind of articles, they're showing more of results of older generation LMAs. So we need to have more studies with the newer LMAs and come up with much more evidence. And this is one particular thing which is really looked at. Should we really abandon the LMAs and adopt the second generation supraglottic airway devices? Because in this particular thing, they looked into some of the supraglottic airway devices in terms of speed of insertion, quality of ventilation, airway seal, aspiration protection, avoidance of the airway trauma, avoidance of some post-op morbidity. And it seemed like IGEL performed much better. Out of 22, IGEL performed 19 scoring. So saying that IGEL is almost as good as having an endotracheal tube and much safer in terms of all these particular things that they look for. And very near to IGEL is now ProSeal LMA with a score of 18. So NAP4, which is National Airway Project that was done in 2011 in UK, which looked into major complications of airway management, found that 56% of the general anesthetics were with the supraglottic airway devices. And there were 33 events that were involved in this particular devices, and there were aspiration, airway trauma, loss of airway during insertion, failed insertion, or displacement after insertion, loss of airway during maintenance, and extubation-related problems. So there were multiple factors that were involved, such as obesity, comorbidities, traumatic insertion, inappropriate use of the devices, low operator experience, non-standard patient positioning, and shallow anesthesia that led to such critical events. So limitation in evidence being, of course, we don't have much of RCT and meta-analysis because most of the literature that is available is showing only on the early phase of use of LMAs and efficacy when it's looking at just ease of insertion, first time insertion, and airway seal. And most of studies have actually focused on efficacy rather than safety. Some minor complications are collected in some of these studies, and that too on the low risk patients. So to conclude, we do not till date have an ideal LMA because it started with Goldman mask cuff some time ago. And if you see on that particular picture, there's so many prototypes that have come up. And we do have so many designs and the kind of different LMAs available in the market, but we need to have those, the so-called the ideal one, which in terms of looking into efficacy, safe by avoiding complication, which is versatile, which is of good cost and kind of reusable. So several different airway will always be needed for use in different clinical situations. So the answer is that we do not actually have one so-called the ideal LMA. That ends my talk, and thank you for your patient hearing.
Thank you, Manjula. It was an excellent presentation with a lot of checking into the literature to support or tell us what is to be done or what is the best way to go on with the available equipment and the technique. Is there any questions? You can put it in the chat box. I request you all to give your feedback to improve our presentations for the future. Any questions? Okay. Shall we move on then? Thank you, Manjula, for being with us.
Thank you, Dr. Smith. Thank you so much.
Good presentation.
Thank you.
Thanks a lot. We'll see you in the future.
Yes.
Now coming to the last part of the program, vote of thanks. We have with us Dr. Gandhi Ramesh, our own staff. I request Dr. Gandhi Ramesh to propose the vote of thanks. Over to you, Gandhi. Dr. Gandhi.
Good evening, everyone. Can you all hear me?
Yeah, we can hear you, Dr. Gandhi.
Good evening, everyone. I, Dr. Gandhi Ramesh, on behalf of Nitte Anaesthesia Educational Series Organizing Committee, would like to deliver the oath of thanks for today. First and foremost, I would like to thank the Organizing Committee of Nitte Anaesthesia Educational Series for giving me this opportunity to deliver the oath of thanks. I would like to thank Dr. Muralidhar Kanchi, who is an eminent teacher and doyen of cardiac anesthesia. One of the signs of a great teacher is to take a complicated topic and to deliver it in a simplified way to a student. Thank you, sir, for doing this. Thank you, sir, for taking the time out from your busy schedule to conduct today's master class on cardiac, today's master's class. Thank you, sir, for conducting such a brilliant masterclass, and you really made it pleasurable to see with your beautiful slides and pleasurable to listen with your abundant knowledge. I am grateful to Dr. Rajesh Mane, Professor and Head of Anesthesiology, JNMC Medical College, Belgaum, and Dr. Rashmi, Department of Anesthesiology, Case Segde Medical College, Mangalore, for moderating the case discussion on mitral stenosis patients coming for in a clinical surgery at this busy hours of the day. I would also like to appreciate the postgraduates, Dr. Sharabanti Jana and Dr. Srinivas Reddy TS, who did a wonderful job at the case presentation and who are from SSIMS and RC Davangere. We would like to extend our heartfelt gratitude to Dr. Manjula Devi, Professor, Department of Anesthesiology at St. John's Medical College and Hospital, Bengaluru, for a wonderful lecture on LMA family. It was a pleasure, ma'am, listening to your talk. I would also like to thank our audiences for staying with us till the end of today's lecture educational series. I am grateful to Nitte University and the department for the enormous cooperation in organizing this event. I would also like to thank all the faculty members of Department of Anesthesiology for their efforts in making this event a successful one. Finally, and importantly, I would like to give my special gratitude and thanks to Dr. Shripad G. Mendale, who has been the backbone of this very beautiful program. Lastly, I thank those who have directly or indirectly helped us in making this educational series a successful event. Thank you, everyone.
Thank you, everyone, for being with us. And most importantly, thank you, Gandhi, for joining us for the vote of thanks. We will meet next month, Thursday, same time, 3 to 5:30 p.m. with a new group of new master class, and an interesting case for discussion and an equipment of the month. Thank you all. Goodbye. Take care.
Bye.
Okay,